So, good morning, everyone. Thank you for joining us on a Wednesday morning for a webinar with Professor Dato, Dr. Cheng. Before I start, I know a lot of you will have a lot of questions for Prof. Please wait to the end of this webinar. You can drop your questions in the question and answer box, and I'll answer, and she will get to them at the end of the webinar. Okay. So, Professor Dr. Yip Cheng Ha has been a key collaborator with Cancer Research Malaysia, contributing patient samples and clinical expertise to many studies within the breast cancer research program, including the Malaysian breast cancer genetic studies called MyBRCA. This cohort now represents one of the largest genomic resources of Asian breast cancer research, enabling downstream projects such as ERICA, Asian Genetic Risk Calculator, tumor sequencing, and multiple international collaborations. Good morning, Prof. How are you doing this morning?
Hello, I'm actually in the middle of a clinic, but it's okay. Half an hour I can take off to talk to you. Okay.
Okay. Thank you I know you have a very busy schedule. It's also Pink October, so we are very, very happy to have you for our webinar. So, Prof, without further ado, I'm going to start my very first question to you. Can you tell us a little about yourself and the work you do?
I'm a breast surgeon in Picaso Hospital. That means I work in the breast clinic here. I see patients with breast problems. I will order mammogram, ultrasound if they need it. And if needed, I will organize a biopsy. And if the patient is diagnosed to have breast cancer, then I will organize the treatment of the breast cancer. So that's my work at the moment. Previously, I was in the University of Malaya, where I run the breast unit there, and I was a professor of surgery in the university.
Okay, thank you, Prof. What is the current situation of breast cancer in Malaysia? I mean, you were in University of Malaya before this, and you were running the breast cancer unit. I'm sure you have an extensive experience and knowledge about the situation of breast cancer in Malaysia.
Yeah, you see, the incidence of breast cancer, we have to rely on data from the National Cancer Registry. So the latest report was from 2017 to 2022. And in this report, breast cancer was the commonest cancer in Malaysian women. And it's estimated that 1 in 23 women in Malaysia will get breast cancer in their lifetime. This incidence is lower than in Western countries. For example, in USA, it's stated that it's about 1 in 10 women in their lifetime. So Malaysia being 1 in 23 is about half the rate that you would get in the Western countries.
Okay. Thank you, Prof.
Yeah.
So, Prof, what is MyBRCA and what was the reason for this? What was the reason for this cohort to be built?
Oh, this one is very long ago because Cancer Research Malaysia started as Cancer Research Initiatives Foundation. It was known as CARIF then. And it was actually formed in 2003, founded by two very prominent people, Tunku Ahmad Yahya, and together with Topuan Aisha Ong. And Professor Teo Su Huang was brought in to be the first CEO of the Cancer Research Malaysia. That was 2022. And in 2023, we started collecting blood from patients in the University of Malaya to check on their genetics. And this is called the MyBRCA, which is Malaysian BRCA cohort. So we started this cohort in 2003. The two principal investigators were me from UM and Prof. Teo Su Huang from CRM. And the aim was to study the genetics of breast cancer in Malaysian women. And initially, it was specifically BRCA1 and BRCA2. We have so far now studied also other genetic mutations such as PALP2 and TP53 and other types of genetic mutations. Now, 2003, this is like over 20 years ago. And over that period from now, over to 20 years, we have recruited over 3,000 women with breast cancer into the cohort. And we have published extensively on the genetics of breast cancer in Malaysian women. I'm sorry, I have a cough.
It's fine.
Okay, continue.
Yeah. So, why did you decide to be a part of this collaborative study with Cancer Research Malaysia?
Well, the objective of the project was in line with my research interest at that time, which was on the epidemiology of breast cancer in Malaysian women. So when I started the breast clinic in 1993 in UM, I had already got a cohort of breast cancer patients. I started the database and I was already publishing data on the epidemiology of breast cancer in Malaysia. BRCA1 and BRCA2 were discovered in the 1990s. And this data that was present then was obtained mainly from the Western countries. So we felt that it was very important to study BRCA in the Asian population as well. And that
Mm.
was why we decided to collaborate on this.
Interesting because our genetics, being Asians, our genetics may be different as well, right? As compared to a
Yes,
Western
yes,
population. So,
yes.
how far has my BRCA come today, and how do you personally feel about its progress?
Well, I think it has actually developed very well because when we started, it was just like a pilot project to see what sort of mutations we had. As we collected more and more data and more women were found to have a BRCA1 and 2, we needed to do genetic counseling and testing because, we need to test their relatives to find out which of them were carriers of BRCA. So if those who haven't had cancer yet, we can offer prophylactic surgery, we can offer increased surveillance. So from just identifying the genetic mutations, it moved to genetic counseling and testing. And now we have even developed a Asian risk calculator, which is specifically for BRCA mutations in the Asian women with breast cancer. And this is a web-based calculator, and we are going to actually launch it next month. We've already done the research on this, so it is actually ready to be used in real time.
Hmm. Yeah, I mean, it's interesting to see how, 1993 you started your clinic and where are we now? It's a huge progress because I think even Erica, something like Erica, it also exists in the Western population, but I understand you can't really use those calculation to an Asian
Yes, we have
population.
also done research on using calculators that we use in the Western population, and we applied it to our Malaysian population. We found that actually it was not very accurate in
Correct.
predicting the likelihood of having a BRCA1 or BRCA2 mutation. Because if we tell the patient you have a 1% chance of having a BRCA mutation, of course, the patient is not going to go for genetic testing and counseling
Correct.
because genetic tests are expensive. So we would test only those that have more than a 10% likelihood of carrying the mutation. If we have a patient where the calculator tells us you've got an 18% chance of having a mutation, we would tell the patient you need to be tested. But again, we have to counsel patient about the pros and cons of testing, because this doesn't affect her alone. It affects her whole family.
Correct.
Sometimes
Correct.
they may not want to know because it might be a stigma to have a mutation in your family.
Correct, correct, correct. So I'm going to ask a little bit something that's a little bit different and not on my BRCA now. Are there any myths and misconceptions about breast cancer that needs to be dispelled?
Well, Malaysians think that breast cancer is due to food or stress.
Mhm.
Everybody asks me, oh, is it in the food? Is it the food? Of course, I say no. You have breast cancer, you can take anything you like because breast cancer is not due to food. It may be due to a BRCA mutation, but only 5 to 10% of breast cancers actually have a mutation. That's why patients will always say, I don't have a family history. I can't have breast cancer, but 91% of the patients do not have a family history. It's not genetic. So 90% of the time, we do not know the cause of breast cancer. Unlike cervical cancer or hepatocellular carcinoma, which is due to a virus, there is no virus associated with breast cancer. So if there's no virus, no cause known, you can't prevent it. The only prevention is actually to remove both your breasts. There's also a misconception that breast cancer cannot be cured because patients always think it's a death sentence. This
Mm,
again is not true. You look at the millions of breast cancer survivors that are out there around the world. Some of them have become very strong advocates, for breast cancer. And some of them, are, even in Malaysia, I see a lot of my patients, 20 years, 30 years, still living still alive, they've been treated. Because breast cancer cure depends on early diagnosis and treatment. A lot of patients diagnosed early, they go and try some alternative. So we always emphasize that breast cancer can be cured if women come in early stages. Because Malaysians believe that traditional and alternative medicine can cure breast cancer. This is definitely not true. I have yet to see any patient cured with traditional or alternative therapy. So I think the problem with Malaysians is that they're all very helpful, you know. If they know somebody have breast cancer, they will go and they will tell them, try this, try that, try everything. And actually, doesn't work. Only Western medicine, surgery, radiotherapy, chemotherapy, all the things that the woman does not want to hear. Those are the only ones that work.
Okay, okay. Um, my next question. Many people think that cancer research only happens overseas. Why should we focus on building research here at home?
Cancer research occurs in all the universities here, and of course, in research organizations like Cancer Research Malaysia. In fact, many, many years ago, we wrote a paper on whether research done in the West is applicable to Asians. Of course, it is not. We need to conduct research in our population and determine if there are differences between breast cancer in Malaysians compared to Caucasians. And we find that even among the 3 different races in Malaysia, there are differences in presentation, biology, and treatment effect. Hence, the importance of doing research in different settings. In fact, in Malaysia, we are very well placed to do ethnic research because genetics are different in different races. Okay, many years ago or so, we published a paper that survival in Malays were poorer than in Chinese and in Indians, even if we adjust for the stage at diagnosis, the age of the patient, the stage, and the treatment received, which means that the differences in treatment could be due to differences in what we call pharmacogenomics, because different races respond to drugs different ways. That's why for example, the farmer will know that in China, they will insist that clinical trials be done in the Chinese population before they approve any drug. So these are very important factors. So we have to do research in our own setting. It's not like we are repeating research done overseas.
Correct. We're
Okay?
just trying it in a unique population here as Asians.
Yes. And here is unique because we have 3 races, so we can
Correct.
do research on all 3 races and look at differences in all 3 races.
Correct. So, Prof, Malaysians are unsure about when they should start going for breast cancer screening. At what age should a woman begin screening and how often should they go?
Okay, for this question, I will refer to our latest clinical practice guidelines for the management of breast cancer in Malaysia, which was published in 2019. So in this publication, screening mammogram may be performed every 2 years in women aged 50 to 74 years old. Why stop at 74? Because all the studies have shown that after 74, there is actually no benefit in screening. Screening means you have no lumps, you are doing a mammogram in the hope of detecting cancer early. And why is it we don't do it below 50? Because 50% of our patients are below 50 years old. This is because when you are young, the mammogram is dense. That means it's not accurate. That's why we don't do mammograms in young girls, because the breasts are very dense. That means the mammogram looks white. Cancer is also white. So if your mammogram is already white, you can miss the cancer. So sometimes I've had women in their 40s or so, they have a breast lump, but the mammogram doesn't show it, you know. We also do a lot of research on breast density, you know, in Cancer Research Malaysia. This was a project we did some years ago, and we find that Chinese women have denser breasts than the other races. In fact, generally, Asians have denser breasts than Caucasians. And you must remember all the mammogram screening studies were done in the Caucasian population, not in the Asian population. So in the Caucasian population, in women aged 50 and above, mammogram has been shown to detect cancer early. So overall, the survival from breast cancer is lower in the women who had mammogram screening. This was the big trials that were done like 30, 40 years ago. And because of those trials, screening mammogram is still the only evidence-based modality of screening. Now, for women at high risk, that means likely to have a genetic mutation. That means BRCA or BRCA2. You need to do not just mammogram, because mammogram is useless when you are young. So we
Mm.
do MRI when you are 30 to 49 years old, because MRI can be done even if breasts are dense. And then we do annual mammogram 40 to 69. And 2 yearly mammogram from 70 onwards. Sorry, I need water. So so our guidelines say mammogram every 2 years from 50 to 74. Now, the American Cancer Society actually advocate yearly mammogram from 40 years onwards. But this is in USA, okay? This is not in Malaysia. And mammogram is well, it takes quite a lot of effort,
Mm.
because in Malaysia, we do not have a population-based screening program, so it's opportunistic.
Mm.
So women go for it because they want to be sure that there's
Correct.
nothing. I usually would advocate from the age of 45 years onwards. There are some that advocate from 40 years onwards. So again, the age at starting mammogram screening is a bit controversial, and different countries will have different guidelines. Even in UK, they actually start only at 50 years old, because it's
Okay.
been shown that below 50, the mammogram may not be accurate. So it might not show a cancer even if there is one.
So if they're below the age of 40, ultrasound would be a recommendation, or would it be not
Actually,
recommended?
ultrasound screening is not recommended because there are too many false positives.
Mm.
Because all those who have ultrasound done, I'm sure you know lah, ultrasound 50% of the time will find a lump and scares you for nothing. This is
Mm.
called false positive. And false positives, you have to do a lot of work to exclude cancer. So anybody comes with a breast lump on ultrasound, which is like 1 out of 2, you have to look at the ultrasound and you have to reassure the woman it's not a cancer, because we have to look at the shape of the lump, the age of the patient, and all that. So ultrasound has never been recommended as a method of screening, because there is no evidence that shows that it reduces the mortality from breast cancer. But
Okay.
still, in China, apparently, and in Taiwan, apparently they do use ultrasound for screening. But there's no evidence that it is useful because of the high false positive
All
rate.
positive. Okay. All right. Okay. Um, so this is the next question that I get quite often. Some women wonder if they go for screening today, could they still develop breast cancer in the coming months? How should we understand what screening really means?
Screening is to look for a lump before you can feel it. So usually a lump has to be 1.5 to 2 cm before it's palpable.
Mm.
Mammogram can find a lump which is less than 1.5 cm. Ultrasound is not that good in detecting cancers, but I've got a lot of women where mammogram is dense and ultrasound picked up the lump. Um, so, but you pick up the lump only at the time they go for screening. So if there's no lumps at the time of screening, that's what we call interval cancer. So in between that 2 years when they go for screening, you can develop a cancer. These
Mm.
are called interval cancers. It's not that common, but we still see it now and then. I've had women normal mammogram, 2, 3 months later, they feel the lump. It's quite
Mm.
common. Not quite common, it's rare, but it does happen.
It does happen.
And the
Yeah.
women get very upset. I just had mammogram 3 months ago. How can I have a lump now?
Mm. So it can
Can
it can happen at any time.
That's
It
why they also emphasize not just mammogram screening. There's such a thing called breast
yes.
self-examination, where you examine your breast yourself. But unfortunately, there was a trial that showed that this did not reduce mortality from breast cancer. So the American Cancer Society and a lot of the big cancer organizations have actually taken breast self-examination off the screening method.
Mm.
Same with clinical breast examination. Clinical breast examination is when you go to a doctor,
Mm-hmm.
every year, and the doctor examines your breast.
Mm.
In in the US, the American Cancer Society also do not recommend clinical breast examination. So I always say, if you don't go for mammogram, you don't examine your breast, you don't see a doctor to examine your breast, obviously you're going to find a lump and it's very big. So over here, we still would advocate clinical breast examination and breast self-examination as a method of screening. Okay,
Mm,
so that is, most women find the lumps themselves. I
correct.
see 10 breast cancers, eight of
Mm,
them would have detected it by themselves. Maybe only two would have detected the breast cancer from screening.
screening. Okay, okay. Prof, in Malaysia, more than half of women are still diagnosed with breast cancer at a late stage. Why do you think this is happening, and what can we do as a community to change that?
You see, in Malaysia, we do not have a population-based mammogram screening where every woman is invited to go for mammogram. You see, screening means you have no lumps and you are trying to find a lump which is very early. And when you find a very early stage breast cancer, your chance of cure is high. Yeah. So why is it women still come late? Because you can find a lump which is 1.5 to 2 cm. It is still stage 1. So a woman can find a lump which is smaller, you know. And screening here is opportunistic, but there are many organizations like National Cancer Society of Malaysia that actually offer free screening. But women are not interested because they don't want to know. Their attitude is that they want to wait for trouble to find them. They do not want, to look
Mm.
for trouble if there's none. Sometimes, if they don't feel their breast, they don't go to see a doctor. They won't find a lump until it's so big that it's obvious that you can actually see
Correct,
it. So that's why
correct.
they come late. They don't want to know. And we have actually done many studies on the uptake of screening. That's why we say that there's no point doing a mammogram, a population-based screening program, because the women are not going to turn up. So various studies done show that only 15 to 20% of eligible women go for mammogram screening, even if it is offered free, because
Mm,
they do not want to know.
interesting. So they are trying to stay away from the trouble, but they may end up getting in trouble because they are not doing the proper checks and taking the
Yeah,
opportunity to
because
go for.
sometimes they feel alarmed. They don't even see a doctor. They go to see alternative therapists. There are
Mm,
lots of all this. It's not just the sinseis or the pomos. Now you have all these nutritionists and all these dietitians and all these so pseudoscientists around that will offer all these unproven
mm.
methods of treatment, which is usually not effective. So by the time they see me, they will have tried other things. So that's why they come with late stages.
Okay. So this is my last question to you, Prof. I understand you have very limited time today. What is your advice will you give Malaysian women to reduce their risk of breast cancer?
There's no way to prevent breast cancer because the
Correct.
cause is unknown for 90% of patients, but there are risk factors that are associated with an increased incidence of breast cancer. There are non-modifiable risk factors, which is your family history, you know. Some more non-modifiable risk factors are like your age at menarche, your age at menopause. That one you cannot modify, because but having children, well, you have to start young now. If you have your children early, you have more children, you breastfeed your children, it reduces your risk. But this also may be non-modifiable
Mhm.
because you cannot really like say that I want to have children now and all, you know. So what is modifiable is actually very easy to do. Exercise has been shown to reduce risk of breast cancer. So moderate exercise about 45 minutes a day. Even just brisk walking, just walk around your neighborhood for about 30 minutes, sweat it out. That is actually very good. That will reduce your risk. And also healthy diet. Even though I say that food has nothing to do with breast cancer, food can make you put on weight. And the most important one of the risk factors is obesity.
Mm,
Obesity increases risk of breast cancer. So if you diet, you exercise, you eat healthy food, that will keep your weight down. And that's actually also very good because exercise and healthy eating also reduce your risk of colorectal cancer and stomach cancer and also other cancers. So these lifestyle changes, these are called what do they call it? The and also reduces the risk of getting the chronic conditions such as diabetes, hypertension,
Comorbidities and all that.
cholesterol, comorbidities, because these are all related to
Correct.
exercise, diet, lifestyle, healthy living, you
Yep.
know. So
Correct.
this
Correct.
is that's the term we use for it. What is that term we use for all these diseases? Mm.
Metabolic diseases?
Uh, NCD,
Non-communicable diseases, is it?
yes, non-communicable diseases, NCD, which is a big thing, because
Yeah.
these are the things that kill you now, diabetes, hypertension, cholesterol. So you should modify your lifestyle so that you are less likely to get all these problems, and also in a way reduce your risk of getting breast cancer and also other cancers such as colorectal cancers.
Okay. Thank you, Prof. Thank you for your time. We have come to the end of the webinar and we have answered most of the questions. I would like to thank you for giving your time. I know you are in the middle of seeing patients at the moment and you've taken a bit of a
Yes,
time to come and support the webinar. And on behalf of Cancer Research Malaysia, we'd also like to thank you for all the support you've given us and continue to give us. It's because of you we can do a lot of downstream work, and Erica was born. And thank you so much, Prof. It's great having you. Thank you. Thank you,
yes,
everyone.
it's been a pleasure to work with CRM for all these 20 over years, Yeah.
Yes. Thank you. Thank
Okay,
you. Take care. Bye bye.
bye.